Good afternoon, everyone. My name is Janice Whitaker, and I'm the CGNE Administrator and Community Liaison. It's my pleasure and privilege to serve as the host of the CGNE Seminar Series. This program is being provided by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Ross and Carol Neese College of Nursing, in collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care PA. Today's seminar is entitled Decision-Making Among Family Caregivers of Chronically Ill Black Older Adults, a Phenomenal Study, will be presented by Dr. Teresa Lundy. Before the presentation, we do have some disclosures and announcements. So Penn State Ross and Carol Neese College of Nursing is approved with distinction as a provider of nursing continuing professional development by the Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission and Accreditation. Participants with a valid RN license who attend the entire Nursing Continual Professional Development Program can earn 1 contact hour. Partial hours are not awarded. The topic of this education is non-clinical, and therefore we did not identify, mitigate, or disclose relevant financial relationships. In order to earn contact hours, Zoom in and out times will be recorded, and the post-event evaluation survey must be completed by registered nurses. If you have a question or a comment during the session, please enter it into the chat, or you can also use the raise your hand feature, and Jenny will unmute you so you can speak aloud. After the presentation, we will put the post-event evaluation link into the chat. We will give you a few minutes to complete it at that time, or you can wait and do it after the seminar, as it will be emailed to you within 24 hours. We do ask that you complete it within 1 week of the seminar, and RNs that are seeking the contact hours, we will get those certifications to you within a month, but we do ask that all attendees complete the evaluation form to provide feedback about this seminar, as well as other data for our Age-Friendly Care PA initiative. If you have any questions or concerns, you can reach out to us at cgne@psu.edu. Okay, so next I'd like to introduce Yozhen Lau. She's one of our CGNE graduate PhD student affiliates. Yozhen recently presented a poster at the Gerontological Society of America conference. The focus of her study involved pain in persons with dementia and apathy in nursing homes. We are thrilled that Yozhen represented our center and college at GSA and are thankful for her introduction of our speaker today.
Thank you, Janice. Teresa Lundy is a full-time assistant professor of nursing at Lehman College with more than 2 decades of experience in nursing and teaching fundamentals of nursing, medical surgical nursing, policy and politics, trends and issues, and community health. She earned her PhD at CUNY Graduate Center in 2020. Dr. Lundy received her bachelor and master's degree and advanced practice certificate as a family nurse practitioner from Lehman College. Her clinical expertise includes gerontology, critical care, community health, and nursing administration. Passionate about quality nursing care and teaching, Dr. Lundy strives to educate and mentor new generations of excellent nurses that positively impact patient outcomes. As a nurse scientist, Dr. Lundy's research interests are family caregiving of older adults, healthcare disparities, palliative care, and cultural diversity. Her dissertation is entitled Exploring Decision-Making Among Family Caregivers of Black Older Adults with Advanced Chronic Illnesses. She was inducted into the New York Academy of Medicine in 2018 and is the immediate past president of the Delta Zeta chapter of Sigma Theta Tau International. She is a lifetime member of the National Black Nurses Association, where she serves as a vice president. She is an emeritus member of the American Association of Critical Care Nurses. Welcome, Dr. Lundy.
Thank you very much. Are you able to hear me?
Yes, we can hear you.
Okay, I can't see the screen. I only see the seminar series.
Okay. I'm not seeing your slides yet. So if you can share your screen with the slides.
Okay, here we go. Good afternoon, everyone. It's a pleasure to be here, and I am very happy to discuss my dissertation that I finally achieved in 2020, and it was entitled Decision Making Among Family Caregivers of Chronically Ill Black Older Adults. And this was a phenomenological study, and so I'm happy to share these results and these findings with you. I don't think I need to say much more about myself because I had a very good introduction already, and I thank you for that. And so I will just go on into my study, but you should know that I began my study because I was very interested in decision-making and family caregivers' experiences. I myself was a caregiver for many people in my family, and there were times when I was confused or I didn't know how to make those decisions, or I was even intimidated or had fear of thinking about someone who I loved and possible they're dying. And so, as with many other Black populations or people, they may have the same types of experiences. So the background. Black older adults have a high prevalence of advanced chronic illnesses among most health indices. And as you can see in the slide that shows, for most health indices such as cancer, asthma, heart disease, diabetes, high blood pressure, obesity, and even anxiety and depressions, Black older adults fare worse than their counterparts. In addition, in terms of health outcomes and death outcomes, Black older adults also suffer more. This data is a little bit more recent from the Kaiser Foundation, and it shows the data of health status, outcomes, and behaviors among people of color compared to white people. And the first column shows the data for Black adults. Okay, the orange indicates worse indices. And so as you can see, no other population, whether Hispanic, Asian, or American Indian, or even I'm sorry, I can't even see that, or Pacific Islanders, none of them have as high indices among health outcomes as Blacks. I also looked at just one of the health indices. This is heart disease that came from the Kaiser Foundation. And indeed, Blacks also have a higher rate or prevalence of heart disease than other populations. So the significance of my study is despite a high prevalence of advanced chronic illnesses among Black older adults, they are more inclined to prefer aggressive treatment, less willing to discuss goals of care, and less likely to use palliative care. Few studies examine the meaning of decision-making for family caregivers of community-dwelling older adults living with progressive chronic conditions in underserved communities. And when I did my research, I found only one study that looked at this same topic, but it was with end-of-life care and hospice. I wanted to look at palliative care and people with chronic illnesses that are living still, but they're progressing in their disease outcomes. So I did do quite a bit of research, which is not usual for a qualitative study. We don't usually look at the review of literature extensively because we really want to get the experience of individuals. However, this started out to be a quantitative study that I didn't find enough information about what the experience was that Black older adults actually had in terms of decision-making and what their family caregivers had in terms of decision-making. So with all that is known about decision-making from an empiric perspective, we cannot understand the meaning attributed to the experience without qualitative inquiry. Understanding the decision-making experience can provide insight into effective strategies to promote quality of life, discussions of goals of care, and to provide culturally congruent care for health, well-being, and the well-being of healthy and dying persons. So the study aims were to explore the lived experience of family caregivers making healthcare decisions for or with Black older adults with advanced chronic illnesses, to explore family caregivers' values and beliefs that influence healthcare decision-making and goals of care discussions, and also to explore family caregivers' knowledge and experiences with palliative care. So my main research question was, what is the lived experience of healthcare decision-making and communicating goals of care among family caregivers of Black older adults with advanced chronic illnesses? To answer the research question, I used a qualitative research approach. Qualitative research allows the exploration of experiences, perceptions, and feelings of individuals and groups within their social, cultural, historical, and political contexts. So where some qualitative research does not want you to be influenced by anyone's social, cultural, and other factors, the type of qualitative research that I chose to use actually allowed for me to consider some of those variables that I was interested in. In this way, unexplained assumptions about family caregiving and decision-making can be examined through the lens of social, cultural, and environmental influences. And this is my immersion. This was my dissertation. I lived, breathed, and kind of slept with these books and many more in this box and other boxes. So when you're doing qualitative research, you become very immersive in some of the philosophical underpinnings of qualitative research. So to this day, I can still smell the oldness of the books, and I can still smell the wisdom that came with some of these old texts. So my theoretical framework was interpretive phenomenology, which focuses on the meaning of experiences embedded in a person's everyday life. It allows one to explore the nature of personal actions and decisions for self and others, which is what I was very interested in. More specifically, I used Max Manin's approaches to human science. These were the philosophical and the analytical underpinnings of the study. So a little more about interpretive or human hermeneutic phenomenology and Max van Manin's 6 approaches to human science. The first approach is to turn to the phenomena of interest. I turned to this phenomena, as I explained earlier, because I was a family caregiver and I wanted to know more about this topic. 2, investigating the experience as we live it. And so I interviewed people who were living this experience so that I could get their perceptions of their lived experience as they were living it. 3, reflecting on the essential themes which characterize the phenomenon. And so this is a very iterative process of really going through the data and trying to extract essential themes and reflect on them and dream about them. And you'll come up with some of the essential themes that we'll talk about later. Number 4, describing the phenomena through the art of writing and rewriting. And this I also spent hours and days and a lot of time doing, okay, writing and rewriting, as some of you, if you're still in the dissertation process, will be doing. And those of you who have finished the dissertation process already know this. Number 5, maintaining a strong and orientated pedagogical relation to the phenomenon, meaning looking at this phenomena as a child, trying to discover whatever is new. So looking at it so that you can gain new insight. And last, balancing the research context by considering the parts and whole. So the methods of this study. I first had to get IRB approval, which I obtained from Hunter College of the City University of New York. The criteria for participation in my study were adults self-identified as a family caregiver, providing substantial support to the care recipient. The care recipient was to be age 65 or older and diagnosed with 1 or more advanced chronic illnesses, such as heart disease, renal disease, COPD. Some had problems with mobility because of arthritis, crippling arthritis, and those kind of diseases. However, care recipients with dementia and advanced cancer were excluded because patients with dementia or persons with dementia already have cognitive impairment. And so they may have to rely on a caregiver to make decisions for them. Whereas if I looked at patients or persons who were cognitively intact, they had the ability to make their own decisions. Whether they made them or not was another story. I also didn't look at advanced cancer because there's a lot of data already that talks about terminal illnesses, especially cancer, but very few that really looked at chronic illnesses and people living with chronic illnesses that are progressively worsening, but still residing in the community. So my participants, I had a purposive sample of family caregivers of Black older adults with advanced chronic illness, and they were recruited from elder care agencies, churches, and through snowball sampling, which was really the most effective way of getting participants, and meaning that one person told another person and so on and so on, and they met the criteria, and I was lucky enough to get more participants in that way. The participants' characteristics, I finally got 11 participants. The age range was from 39 to 65. 9 were caregivers of their mothers. 1 was a caregiver of the grand uncle, and 1 was a caregiver of a grand aunt. 6 were registered nurses, and 3 were advanced practice nurses. Data collection. Data was collected through semi-structured interviews that I allotted 60 to 90 minutes for. The participants were offered a $25 Amazon gift card for time and participation at the end of the interview. For most participants, they didn't even expect that they were going to get anything for the interview, except the ones that I had already interviewed, and by word of mouth, they knew that they would get compensation. One participant refused the compensation. Trustworthiness. That is, in quantitative research, we would call it reliability. In qualitative research, it's referred to as trustworthiness. How is your data made so that the public can trust what you're saying? And that was maintained by audio taping the interviews, by journaling before and after the interviews. Any feelings that I had, I put down prior to, and any feelings that I had after, I put down in my journal after the interview was completed. Also, bracketing. Bracketing is a way of holding in abeyance your own thoughts and your own feelings and possibly your own biases. And so for me, to bracket involved not only journaling, but also centering. So I used to listen to meditative music before I actually went on my interview. I'd look at the questions, the interview questions, so that I'd have an idea and I wouldn't have to look at notes. And I would just relax and be centered so I could actually be present during the interview. I elicited detailed descriptions and anecdotes from the participants. This through open-ended questions and other types of probing questions. Tell me about your experience making decisions for or with your mother, your father, or whoever it was that they were taking care of. And then after they would give me some description, if I really wanted to know more, I would say, what's it really like to do this? And they would come up with even more rich information. That was a technique that Van Manen had suggested as a way of really getting to the heart of what the person was experiencing. I also did careful coding, putting the themes that were emerging into patterns and being careful to code them correctly. I also looked for themes, patterning for themes. And that involved going through all of the interviews one by one and all together, and then really synthesizing and coming out with and extracting the themes. And through peer support. My dissertation committee was very supportive. However, it was two people that really provided the most support in terms of looking at my interviews and seeing, was I getting the themes that I thought I was getting? And even just supportive in that I was on the right track, because during a dissertation, you become overwhelmed and then you wonder, am I doing this right or whatever. So my dissertation chair, Dr. Capizzuti, as well as Dr. O'Connor, Susan O'Connor, who is an expert in qualitative research, were very helpful during this time especially. So for thematic analysis, each interview was transcribed and reviewed several times. I transcribed them personally, as well as I got software also to transcribe the interviews. And as a novice researcher, I did several ways of analyzing the data: holistic, selective, and detailed coding using Atlas TI, a software program. So that means that I looked at the whole interview and then got a sense of what the themes were. Then I looked at selective paragraphs, each paragraph basically, and got some themes. And I even looked at line by line to analyze the data. The responses were coded and categorized based on the research questions, also based on the decisional dynamics, meaning who made the decision and how was it made, and by Van Manen's 4 fundamental existential themes of lived times or temporality, lived relation or relationality, or also known as lived other, lived body or corporal reality, and lived space, spatial reality, spatiality, I'm sorry. And so here are my results. 3 essential themes emerged. 1, living out commitments with intention. 2, making meaningful decisions situated in context. And 3, learning from the past, anticipating the future. But how did I get to these findings? This is a map of how I derived my essential themes and eventually my integrative interpretive statement. So as an inductive strategy for research, we go from specific to general conclusions. So therefore, I started with fundamental meanings, which then transformed into preliminary themes, and then transformed into interpreted thematic statements, and then finally, the essential theme. So essential theme number 1, living out commitments with intention, was derived from the fundamental meanings of personal commitments, values and beliefs, empathy, enduring trust, shared togetherness, and mutuality, which then led to the preliminary theme of committed embodied relationships, which I then interpreted as the thematic statement. Shared togetherness is revealed in trusted, committed, embodied relationships. And then finally, essential theme number 1 emerged, as I said, living out commitments with intention. So one participant said, everything I do is for the good of her care. Essential theme number 2 was derived from the fundamental meanings of emergent versus non-emergent decisions, managing uncertainty, decisional outcomes, communication, and situated freedom. Meaning, did the person ultimately had, the care recipient ultimately had the situated freedom to make their own decisions because they were not cognitively impaired, but how the decision was made was actually looked at. Preliminary themes was the next to be derived, and that was revealed as decisional dynamics and decisions guided by situations. The interpreted thematic statement was derived as meaningful decisions are guided by situations that aim to guard, protect, and comfort vulnerable family members. And finally, essential theme number 2 was derived, and it revealed making meaningful decisions situated in context. One participant said, Mom, we're gonna get a pacemaker. Your heart rate is 38. You can't stay like this. Obviously, this was one of the RNs, the nurses that was in my study. Okay, finally, essential theme number 3 was derived from the fundamental meanings of learning from past experiences, anticipating decisions for self and others, and questioning assumptions. The interpreted thematic statement was reflecting on the past can motivate, Preliminary themes were reflection and anticipation. The interpreted thematic statement was reflecting on the past can motivate caregivers to act in the present and anticipate the future. And then finally, essential theme number 3 emerged as learning from the past, anticipating the future. One participant said, if anything ever happens to me, you guys know that she's taking care of everything. Don't fight with her. Conflict was another theme within a theme that sometimes came out of some of the narrative experiences. Finally, essential theme number 1, number 2, and number 3 were combined or re-examined, reanalyzed, and an integrated interpretive statement was created. And that was living out commitments with intentions of making or helping to make meaningful decisions that value the person, reflect past experiences, and anticipate the future. Other findings showed that values and beliefs permeated the 4 foundational themes, Van Manen's 4 foundational themes of live time, live space, live body, and I forgot the other one, but it'll come back to me. Okay, values and beliefs permeated the 4 foundational themes, and many foundational themes overlapped or were inseparable, as I will show you in a few minutes. According to Van Manen, the 4 existential themes of lived body, lived space, lived time, and lived relation can be differentiated but not separated. And decision-making was a fluid and dynamic process. Family caregivers' attitudes and behaviors were influenced by cultural expectations, past experiences, and the desire to make changes if needed. So I also analyzed each of the themes through the existential themes that Van Manen had espoused. So lived relationship. These are vignettes that come from the interviews. One person said, I had a very close relationship with my parents, but making decisions and dealing with changes she's been going through is tougher than I thought. I thought that because we had such a close bond all my life, that it would be easier. But I found that it's harder. And I think sometimes it's harder because she's not understanding where I'm coming from anymore. It's not the same. Another participant said, it's not what you expect. I mean, as a nurse, I understand the process of aging, but it's very personal. It's very unique. Not everyone ages the same. I see the temperament changes. So a lot of times she's angry, a lot. And I don't know, that hurts more than anything. I don't want her to be angry. I can't control that, so that hurts. I don't want her to be angry for her last days. And another participant said, my mom said, no sooner than I left the hospital, a doctor showed up with a paper for her to sign. And he said to her, you're going to actually let your daughter make decisions for your life? This is your life. If you don't get the surgery, you're going to die. So my mother says she told the doctor, I trust my daughter with my life, and I'm not signing anything unless she's here. These vignettes show the closeness within these relationships. Lived times or temporality. This is Nia's experience, which provides insight into generational and cultural expectations that play a role in whether goals of care or end-of-life care are discussed or avoided. Reflecting on the past, anticipating the future. Watching my mother go through stuff with my grandmother when she was in her final days or final hours. I don't want to do that with my siblings. It was a lot. Should she be put on a machine? Oh, we're not going to sign the paperwork. I don't want to go through that with my siblings. Even if it comes to me, I don't want my children to go through that. My grandmother never had anything in order, and neither did my grandfather. My grandfather, his last few days, nothing was in order. Everybody trying to call the shots. 2 deaths, and it was the same thing each time. Mommy wanted this or mommy wanted that, but mommy never actually said what she wanted. It actually broke my family apart for a while. I just think that if you have that one person and you say to that one person, okay, you're in charge, you know what my wishes are, have it done in paperwork where everything is signed. It makes it so much easier. Within that context, you can not only see lived times and anticipating the future and reflecting on the past. Lived space. One participant said, she, referring to a mother, says, I don't like Florida, but when you go there to live, I'm going with you. She didn't ask me. That's why I haven't gone, because it's more beneficial for her to stay here for care. That also shows not only space, it's a felt space as well as geographical space. Another participant said, sometimes her siblings think, just put him in a nursing home and he'll do fine there. You don't have to worry about anything else. But you have to think that this is a man who still understands what's going on. They don't understand that kind of psychological piece of the attachment of wanting to be home, because he worked for over 50 years to build this. So anything that happens, they say, see, if he were in a nursing home. So guilt was another thing that also emerged as some themes that came out through family relations. Lived body or embodiment. Corporal reality means that humans present to the world in a physical body and always reveal some things while simultaneously concealing something else. Van Madden, 1990. In the middle of the summer, she, her mother, said to me, I want to tell you something, and I'm so ashamed. And I said, what are you ashamed of? And she says, I can't remember. She said she couldn't remember someone's name. And she said, and I said, Mom, that's okay. That happens. And she said, but I haven't told you everything truthfully. What do you mean truthfully? And she said, I'm having problems remembering things. Her eyes filled with tears. Then that's when I knew. I had recognized, but for her to say it hurt, really tore me up. So in this case, concealment, revealing and concealment, and secrets show the relationship and the embodiment of both the daughter and the mother, who were both relieved once the secret was revealed. Pedagogical relationships. Pedagogical relationships are distinguished from other adult-child relationships because the parent is typically the teacher and the decision maker. Tensions arise as adult children assume more responsibilities for caregiving and decision-making, but are still viewed as children or when values conflict. Here's an example of what one participant said. I felt more like the parent than the child. Another one said, I'm her child, so she may think I don't really know what I'm talking about. I'm an adult and a senior. She was over 60. So I've been around the block. Even though it's your parent, you love them dearly, you try to explain to them, but they still think of you as a child. And finally, one participant said, once again, you're just agreeing with those doctors. Give me more pills, give me more pills. I'm tired of pills. This was an example of values conflict. Her daughter was a family nurse practitioner. So she was very much into the medical model. Her mother was very much into the holistic model. And so she resented being told what to do at times, especially if it had to do with the medical model. And her daughter felt guilty about it at times. Decision-making was a fluid and a dynamic process. Most decisions were made collaboratively. These are other findings. My mother is still with it enough that I don't make decisions independent of her when it involves her. 5 participants had never heard of the term palliative care, while 6 RN participants had prior knowledge, but they also equated palliative care with hospice care or with end-of-life care. And so as nurses, we don't quite understand what palliative care is. Most participants had no knowledge of community palliative care and were unaware of the availability or accessibility of services. So palliative care in this case is differentiated from hospice care because hospice care requires or typically has a 6-month prognosis. The person has a 6-month prognosis. Many people who are in hospice care die way before that 6-month prognosis because they sometimes delay even going into hospice. Palliative care can be given along with medical treatments. So a lot of people don't know that. They equate palliative care and hospice care. And so they think that if I say yes to palliative care, that means my loved one is going to die. And so there was some value conflicts as well as lack of knowledge in terms of what is out there in terms of palliative care. Other findings were we're doing it. This is what a lot of, several of the participants felt. They were taking care of their parent or their loved one. They were given the pain medications as ordered. They were working with the medical team and also doing holistic treatments. They might be doing yoga or taking them for a walk or trying to get them to be as active as possible. And so when I explained to them what palliative care was, they would say, we're doing that. We're doing it already. And one participant said she was offered palliative care as an option for her father during his final days. So a lot of times, the only time people are addressed or are asked about palliative care is when the person is in the emergency room and they're dying. And that was the case of this one participant. So here are my considerations or limitations. In quantitative studies, this would be called a limitation. And I had to really go into my brain to come up with some other term because I felt that this wasn't really a limitation, but it was something that you need to consider in the context of research. So more than half the participants were registered nurses with current or prior home care experience. So that influenced the outcome because they knew more about palliative care and patient care and medical conditions. So that's why I would say that that might be a limitation or a consideration. This was a homogeneous group, but it was a purposive sample. So all of my participants were females and most were caregivers of their mothers. But consistent with qualitative research, findings are not generalizable, but transferable. So conclusions and implications. For African Americans, avoid using terms such as end-of-life care and focus on goals of care or care preferences. It tends to create death anxiety. And so just the terms alone can mean that a person will avoid talking about it. RN should have an active role in interdisciplinary teams and palliative care programs, allot adequate time to address care preferences in primary care settings, designate trained and relatable staff to address goals of care and end-of-life care, integrate content and experiences throughout the nursing curriculum. Community partnerships and educational programs are needed. For example, during my research practicum, we did a program called Palliative Care 101 in the Community Senior Center, and we taught the participants about palliative care. We were able to give them advanced directives, tell them about healthcare proxy, and they didn't know about it in general, and they were happy to get the content. There was some skepticism initially, because as the only African American in the team that was approaching them, they would ask me, why are you asking me for this information? And what is this about? With some sense of suspicion. Some of this comes from mistrust of the healthcare system. And some of this comes from mistrust, thinking that, why would I want to end my life or hasten my death? And so it does help to have people of the same background talking about this information. On the other hand, it also helps to have people that understand how to talk to people about end-of-life care and decisions. So trained people would be very helpful. Advocate for funding and accessibility of community palliative care in underserved communities. This study was done in the Harlem community and the Bronx. Those are the main areas that I actually got my participants, which are underserved communities in many aspects. Develop innovative, holistic interventions to assist family caregivers and care recipients in decision-making. Recommendations for future research and interventions: examine the collectivity of family decision-making, because sometimes families make decisions collectively as a whole and not just as individual caregivers. Recruit more male family caregivers to explore differences or similarities in findings, and to compare experiences of family caregivers of other cultures, ethnicities, or races with the experiences of Black or African Americans. And so reflections. There are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need a caregiver. Rosalind Carter. And to seek to know and to understand designated cultures with their values, beliefs, and daily living patterns is probably one of the greatest challenges for students of human behavior. Madeline Leininger. And here are my references and my acknowledgements. I would like to give special thanks to my faculty advisor, Dr. Elizabeth Capizzuti, and also to my committee members. I would also like to give thanks to Donna Nikitas, Daniel Gartner, C. Alicia Georges, Susan O'Connor. I express my heartfelt gratitude to the 11 participants who shared their unforgettable stories with openness. And many thanks to the Center for Geriatric Nurse Excellence and Penn State Ross and Carol Neese College of Nursing. I'd also like to acknowledge Dr. Eileen Engelkike, Dr. Kevel Fredrickson, and Dr. Marie Boltz, with whom I would not be able to share this day and these experiences without their networking and their support. And finally, let me thank Jenny Rank, who has been invaluable in helping me to present this program. And with that, if you have any questions, this is my contact information, and any questions, I'll be happy to answer.
Well, thank you so much, Dr. Lundy, for this amazing presentation. I can see why you put that image of all of the books on top and around the desk, because this must have been a pretty intensive study. It's very comprehensive, so informative, and so incredibly valuable to nurses and other care providers of, people with chronic illness. So thank you so much for the presentation. We will take some questions and comments in a few minutes. There is one in the chat right now from Troy Dunstan. He says, Dr. Lundy, thank you for an informative and impactful presentation. I also appreciate all your efforts in advocating for those who are underserved and underrepresented in the caregiving arena. best wishes to you on all your future endeavors. Take care and stay safe. So I think we all share those sentiments. So thank you to Troy for sharing that in the chat. We're going to pause for just a couple minutes to allow people to do the survey, the evaluation of the presentation. So we'll take about 3 minutes to do that. We can also have people put questions and comments into the chat at this time, and then we'll return again to get more feedback from Dr. Lundy. Hey, if you're still finishing the evaluation, please go ahead and complete that process. But I'd like to resume since we only have a few minutes left. I want to give people an opportunity to share comments or questions with Dr. Lundy. So Erica Husser is stating, what a fantastic presentation. Your theoretical framework is great, and your analysis and findings are insightful and stellar. Thank you for such a clear presentation of your analytical process. Do you consider interviewing the older adults as well as the care partners?
Oh, that's such a good question. That's what I would like to do. And that's not on my future research, but honestly, it's a symbiotic relationship. So I would really like to study that. That would be great.
It'd be really interesting. I love the approach you gave to analyzing the wealth of information you had was just amazing. And how you were able to come up with the themes and then the sub themes under them. And they seem so, as Eric is saying, so meaningful and insightful. So thank you for sharing that.
Thank you.
Another thank you from Tracy Wilhelm. So one of the things I would, oh, is there someone unmuted? Am I hearing? Okay.
I think there's 2 questions in the chat that I see. Logan Sweeter asks, she said, first of all, thank you so much for such a wonderful presentation. And she asked, when you were in the process of selecting a software program to analyze such complex data, what kinds of things did you take into consideration?
Another great question. I actually used one program before. I used Atlas. And what I found is that you have to do the work. Sometimes we think that you're going to get all of the themes and just put it in a program. No, you're actually doing the patterning, but the software helps you find anecdotes that go along with the themes that you're developing. So if I had a pattern and a theme, I could, just put in the theme, and then it would come up with several anecdotes that I already selected and named this or labeled as this theme. So it is helpful.
Yeah, and those quotes you shared, were so meaningful, so impactful, and really relevant to some of those key concepts that you came up with, like the closeness in the relationship, the conflicts that were inherent, even in that one that said they had always been close and able to make a lot of decisions together. But during this part of their life together, that things were much more challenging. So thank you for sharing all of those quotes. I think they added a lot of meaning to your presentation. Diane Barish is saying, thank you so much for a great example of qualitative research. I'm curious what you would see as future local, state, or federal policy change that would have the greatest impact on supporting care partners.
Okay, that's another great question. And policies regarding access to palliative care, especially in the community, would be very relevant. We don't really have a lot of policies regarding that. And reimbursement is sometimes a problem. Lots of people don't know that it exists, and it does exist in some underserved communities. And so policies regarding either reimbursement or access to palliative care services in the community would be helpful.
Yeah, and I found it interesting that as part of this whole work, you did a community presentation specific to palliative care. Did you find that people gained knowledge and an understanding of the difference between palliative and hospice care, as you described that there was some confusion around that?
Yes, what I found is after the presentation, we did a survey to find out if they actually was able to understand palliative care. And overwhelmingly, they knew much more than they did before they came. They really knew nothing before that time.
Yeah, and that was especially interesting because you said that, you know, more than half of the care partners were nurses in your study. And even those nurses, you know, were not able to describe the differences between palliative and hospice care at that time.
Yes.
That's
And
very
so
interesting.
if we as healthcare professionals can't differentiate, then lay persons are really going to have a difficult time.
Right. I also found it fascinating in your findings. You were talking about the terminology that was more comfortable for some of the participants in your study, that using terminology like end of life seemed to cause them some anxiety. So can you speak a little bit more about your experience with that?
Yes, there was a lot that came out as well about culture, spirituality, whether you say something, will it talk it into existence? I didn't go into all of those things in this presentation, but there's a lot of background in terms of faith, healing, not saying things that you think will happen, so avoiding the topic. Those things did come out in many cases, and death anxiety. I know when I grew up, if my mother said anything about dying, it was like, no, we don't want to hear it. It's taboo. This is as a young child, but when things happen, it kind of pushes you in the direction of saying, I wish I knew. So maybe it's something that I could share with others so that they would know.
Yeah, well, thank you for sharing that perspective. Troy also put in the chat for those that are interested. Here's a promising response to the need for more assistance and support for caregivers. The 2022 National Strategy to Support Family Caregivers. So take a look at that. The link is in the chat. I'm afraid we're out of time, but I'd like to thank Dr. Lundy on behalf of all the participants here today, as well as our Center of Geriatric Nursing Excellence here at Ross and Carol Neese College of Nursing. Thank you so much for this amazing seminar and for all the incredible work you're doing.
Thank you very much for having me, and have a blessed day, everyone.